Meanwhile, the Nevada Democratic Party is preparing for its caucus about Saturday. The state relate the results smoothly. The app doesn't cause any problem. And has a great story about journalism. Sharing customer data with marketers. If you're worried about keeping your camera microphone on. Studying the work of a photographer from Harlem, Sean Walker. Negatives from his collection.
Hello? Tanya? Hello? Oh. Oh.
Everyday products, most they want to use. The app says it's going to level of safety and protect.
It's just so tied to my slides. Okay. So, a lot of stigmatized characteristics of individuals, and new stigmatized conditions are emerging all around. We're seeing, in fact, I was just talking last night with Mike Morrison about acts of pretty heinous discrimination and violence against people that are being perceived as related to coronavirus, and this is a current problem really everywhere right now. So stigmatized conditions emerge. I think if you voted for President Trump, it's a stigmatized condition. HIV stigma is related to multiple aspects of having this virus or being perceived as having this virus. The virus, of course, itself isn't stigmatizing. It's what people believe in the social constructions around it. So HIV is stigmatized as a contagion, a perilous condition. These are Goffman concepts. As a sexually transmitted infection, its association with drug use and as a terminal illness. And HIV has been called divine retribution. It's a gay disease, an African disease, a disease of the poor. It's a political agenda. It's a disability. It's a cost to society. And this list could just go on. So the baggage around HIV infection that is really what the stigmatization can be attributed to is a long list. And HIV stigma is everywhere. All it takes is a simple Google News search for those terms, HIV stigma, and on any given day, you'll see multiple news articles from all around the world that have those key terms, HIV and stigma. So it's a prevalent problem. There are contemporary models of stigma that we've relied on quite a bit in our work that I think have really helped to clarify some of the key concepts around stigma. Our work is very much driven by ideas that Valerie Earnshaw, she's actually this year's award winner for the APA New Investigator Award, actually. She was, and last year she received a New Investigator Award from the NIH. It's actually for her work in stigma across diseases, but she's most well known for her HIV stigma research. She has a framework that draws on concepts that have been in the literature for quite some time. But what is nice about Valerie's work is that she presents them in a formal and testable format, in a model that actually is testable. So she talks about stigma that's attached to HIV, that impacts people that are uninfected and people that are infected. And she translates these concepts into mechanisms that map onto outcomes and that really provide opportunities for interventions. So for the uninfected, which is what we should really be thinking about in terms of prevention, HIV stigmatization leads to prejudice and stereotypes and discrimination. And the outcomes associated with that are things like social distancing and HIV testing and PrEP uptake, we would say, and policy support. And then for people that are living with HIV, the concepts are translated into enacted stigma, anticipated stigma, and internalized stigma. And these have implications for outcomes around mental health, support, and engagement in care. And so she has presented testable path models for how, in people with HIV, how internalized, anticipated, and enacted stigma can be used to predict health outcomes, mental health outcomes, and support kind of outcomes. Now, these stigma mechanisms that Valerie has talked about map on nicely onto the continuum of care, and that's true for the PrEP cascade. Anticipated stigma and stereotypes and discriminatory policies and internalized PrEP stigma impact each of the steps along what we call the PrEP care continuum or the PrEP cascade. So PrEP stigma here, we're seeing quite a bit of research that's actually informing how we might try to scale up PrEP. Is going to be impeded in some places for sure by PrEP-related stigma. I like this study published by Brian Mostansky, and he probably could have published this in a better journal. It's in AIDS and Behavior, where they did a mapping study in Chicago. Where they mapped PrEP stigma across different areas in Chicago. This was a study of 690 young men who have sex with men and trans women in Chicago. And using GIS mapping analyses, they were able to show that PrEP stigma hotspots, where PrEP stigma is quite high, is concentrated in neighborhoods on the south side of Chicago with high HIV incidence and high concentrations of racial minorities. Whoa, that's very sensitive, isn't it? And the low PrEP stigma areas, PrEP stigma cold spots, are concentrated along the North Shore in communities that have very high HIV prevalence and low LGBT stigma. So this is helpful because it informs us about what we might need to do to scale up PrEP in some areas, addressing stigma or not. Work by my colleague Lisa Eaton has focused on stigma. She actually has been driving, she's been kind of a driving force in I think in the whole area, but certainly has had a major influence on me. And one of the things she's been looking at has been PrEP stigma. She did an interesting study with Black men who have sex with men in Atlanta. And in this study, they looked at PrEP stigma as a barrier to PrEP interest and potential uptake. And what she found was that people that are Black men who have sex with men who are interested, who indicated that they might be interested in learning more about PrEP, were less likely to endorse PrEP stigma-related items. In a different study, what she did was she modeled the relationship between experiencing healthcare-related stigma and seeking health-related care for sexual health among Black men who have sex with men. And she showed that experiences of having felt like I've been discriminated against or stigmatized in healthcare settings predicted the amount of time and the willingness to go for sexual health checkups directly, and also was mediated, and it's a significant indirect effect that she found connecting those stigmatized experiences to health-seeking behaviors were mediated by global medical mistrust, which is another construct that seems to be important in understanding healthcare-related stigma experiences. And stigma mechanisms, of course, also map onto the HIV treatment cascade. And so Valerie's concepts of enacted and anticipated internalized stigma, which have been in the literature for some time, but she's been able to sort of put into a more testable, well-specified model, would say that anticipated stigma is directly related to getting HIV tested and diagnosed and getting into care and being retained in continuous care. And internalized stigma is related to being engaged in care as well as health outcomes, viral suppression. And both of those are really driven by stigma-related experiences and discrimination. So some work that I've been involved in Uganda has been looking at stigma and in relationship to HIV testing. This is actually a fairly large study that Susan Keene is the PI on. This is a study that's an engagement to care study in Uganda. And so far, the data that I'll present to you was about midway through the study. It's about 10,000 people that were tested for HIV in household surveys. That study is now, I think, done enrolling, and they've tested over 22,000 people in villages in rural Uganda and to detect people living with HIV to do their engagement to care trial. They've done a lot of testing. So about midway through, we looked at some of the stigma data that Susan has collected. And what we were interested in was how stigma in these communities may be related to testing uptake. And so like in many places, maybe every place, there are gender differences in HIV testing. Women tend to get tested more than men. It has a lot to do with prenatal care, has a lot to do with women just being engaged in healthcare. I think we all know that. So she sees that in her data. And then what we did was we did a GIS kind of an analysis where, like what Mastansky did in Chicago, we mapped stigma scores onto these, household level data in these rural Ugandan villages. And then if you're not familiar with this GIS kind of an analysis, it tells you actually a lot of different things. She had geolocation data from the household surveys that she was doing. And so all these people were, offered an HIV antibody test after they did this survey that assessed their stigma and their HIV testing experiences and a lot of other things. And in the GIS analysis, an individual's stigma score is mapped onto their neighborhood and their neighbors based on distance metrics. And so you can have an individual who lives in a high stigma area or a high stigma person living in a hot spot. You can also have a high stigma person who lives in a cold spot, who lives in an area of low stigma. You can have an individual who's got low individual stigma score, but they live in a hot spot. And then you have people who have a low individual stigma score, and they're surrounded by low stigma people in a cold spot. So we use those kind of data in that analysis to look at HIV testing in men and women. And what we saw was that for women, as I think we would predict, that women who live in the low stigma areas are more likely to have been tested more frequently, especially women who themselves have low stigma scores and live in a cold spot. They're more likely to have been tested more often. And when we did a multi-level model, Poisson kind of a regression predicting testing, what we see is we see those results that high stigma women are less likely to have been more frequently tested than low stigma women. High stigma communities have less HIV testing see than the low stigma communities. And women who are high stigma in a high area, high in a low area, low in a high area, they all are less likely to be tested than the reference, which is low stigma women living in a cold spot. So they're actually, since by, I think we used at least a few kilometers. So these areas, they're not the same. That's a good point, because they're not the same as villages. They're not like high, low stigma villages. They're areas within these fairly small villages, but they are separated by a distance. But it doesn't look that way for men. For men, actually, it's the opposite. Men who are residing in hotspots were related to the highest rates of testing. And it didn't matter if those men were living in a cold spot or in a hot spot. Men who had the high stigma, who had, I'm sorry, it didn't matter if they had high or low stigma scores. If they were in a stigma hotspot, they were more likely tested. So it's a very interesting finding. And in our multi-level model, we see that areas with high community stigma for men are related to more HIV testing for men. And that's and men who had high stigma scores themselves, who lived in hotspots, had the highest rates of testing frequency. What about stigma here? And so stigma here, we're doing a bunch of work in, my work is all concentrated in the state of Georgia and in South Africa. And in Georgia, we used to do all of our work in Atlanta, but for the past 6 or 7 years, we've been venturing out of Atlanta into central Georgia. If you're familiar with Georgia at all, there's a small city called Macon, where Mercer University Medical School is. And so we've been doing quite a bit of work there for some time now with Harold Kantner, who's an infectious disease physician there and has been there for a long time and has seen really the epidemic in central Georgia evolve. So we're very fortunate to work with Harold. In a study that we did with 696 people living with HIV in Georgia, North Georgia, which is really the Atlanta metro area, and in Macon and its surrounding rural communities, we looked at how internalized stigma was essentially mapped onto population density. And we saw that actually internalized stigma among these people living with HIV was higher in rural areas. We're not the first people to find that. And so it's consistent with other research that suggests that stigma is higher in rural areas and urban areas. And so we use zip code level data that's available to look at population density and how it's related to stigma experiences for people living with HIV in those almost 700 people. And what we see is that internalized stigma and number of years living with HIV and age were significantly related to population density at the zip code level. And then in an adjusted model, it's really just internalized stigma that is related to population density. So the higher the population density, the less internalized stigma people were saying they were experiencing. And then at a community level analysis with those data, we saw that rural areas have greater internalized stigma than large urban areas. This is at the community level. And the anticipated stigma is a trend, and enacted stigma is significant for people in small urban areas, really the Macon metropolitan, I guess you could say, the Macon city limit area having less anticipated stigma than large urban areas, so which would be Atlanta. And so there's almost, I'm tempted to say, although it's technically not correct to say, that there's this linear relationship between population density and internalized stigma. In using a different set of data, different participants, 198 people living in the Macon area, receiving their care from this clinic that we work with in Macon. We did another mapping study, and in this study we were interested in looking at income inequality at the census tract level and its relationship to stigma among men and women living with HIV. And so using GIS again, we were able to look at multiple dimensions at the census tract level. We had income inequality. At the individual level, we had internalized stigma scores, and we also had from their medical records if they had a detectable or an undetectable viral load. And so this is an example of the kind of mapping that we can do, and we see that it's a nice sort of visualization where you can see that, you know, darker regions represent greater income inequality at the census tract level. Each of those blocks is essentially a census tract. Each dot represents a participant, and the colors are coded from low to high stigma, green being low, red being high. And if the dot has a plus, they have a detectable viral load, and all these people are, at least to some degree, engaged in care. We recruited them from the clinic waiting room. And so among women, we see that greater income inequality at the census tract level and greater internalized stigma is associated with their medical record that having a detectable viral load. And we don't see that in men. In fact, in men, income inequality and internalized stigma were not related to having a detectable viral load. And so it's quite different from the women. And that's a familiar thing. I just said that about a different thing earlier. It's kind of remarkable to me. So explaining the association between stigma experiences and viral suppression is something that we were interested in doing with a separate sample of 251 patients at the Central Georgia Clinic. Now these people were followed for 1 year, and over the course of the year, we did our monthly unannounced phone-based pill counts. And as a part of that phone interview each month, we asked them if they experienced 9 different enacted stigma experiences, HIV-related discrimination kinds of experiences. And then we can aggregate those over the course of the year, essentially, having 118 possible enacted stigma experiences over the course of the year. We also asked them in that same phone interview an HIV-related stress measure, and we also asked them about their alcohol use. The alcohol measure is actually a daily measure that's done 14 days in 14-day periods, and we do like 8 of those 14-day periods over the course of the year. So this is a year's worth of data with these people, and so we were able to aggregate the stigma experiences, aggregate the number of days that they drank alcohol, aggregate the stress that they experienced each month, and we had their adherence data every month, and we looked at the final few months. And so in this study, what we were looking at is the aggregation of cumulative enacted stigma experiences as a predictor of their medication adherence, their ART adherence, in the last 3 months of this cohort experience. And we see that the more enacted stigma people experience over the course of the year, the lower their ART adherence was. So we had a model, and we thought, well, maybe the relationship between stigma and adherence is accounted for by stress and alcohol use. All these things we know are related to adherence. We know that people who are under more stress have poorer adherence, and we know that people who drink more tend to have poorer adherence. So we thought maybe there's using our prospective data, maybe there's a causal relationship that we can draw between stress, feeling more stress from the stigma, relating to more alcohol use, which might be accounting for these relationships in ART non-adherence. And the answer is no. So actually, stress was unrelated to alcohol use, and the enacted stigma experiences over the course of the year were unrelated to the year's worth of alcohol use. Alcohol use predicts non-adherence, as it seems to always. And the relationship between stigma and stress and non-adherence was significant. So the answer is no to our model, but there was only one indirect effect that was significant, and it was enacted stigma through stress predicting ART adherence. So we really have a simplified model where alcohol use predicts non-adherence, and over and above that, the relationship between stigma through stress predicts non-adherence, as well as the direct effect of stigma on adherence. We think that this is an important insight into a lot of the data that we've been looking at in that part of, at least in that part of our research down in Macon. So what about stigma there in South Africa? We've been doing some work in South Africa for quite some time, but only recently have we been doing work focused on antiretroviral adherence. It's actually a very new thing for us down there. Our work in South Africa has been more focused over the years on venue-based kind of prevention and interventions and STD clinics for people that are not necessarily HIV positive. But over the past couple of years, we've shifted our focus and started doing antiretroviral adherence kind of research like we've been doing here for some time there. So I kind of like this picture because it says a lot. I think it says a lot. So it's actually an anti-HIV stigma campaign in South Africa, which, I mean, it could just be me, but I think it's actually fairly stigmatizing. So in one of our studies that we've recently done down there is a waiting room survey of people receiving antiretroviral therapy at a Cape Town Township clinic. And in our survey, we asked people about their ART adherence, and we asked them about the barriers that they perceive to taking ART, and we asked them if they have not taken ART intentionally. This is something we've been interested in for some time. Intentional non-adherence, when people forego or skip taking their ART or skip picking them up for a variety of reasons. We've done a bunch of work around alcohol use and people's beliefs around alcohol use as a reason why they just skip or stop taking their antiretrovirals. Recently, we've been doing that same kind of measurement, but asking about social contextual factors, situations where people might be around or family might be around, or they might have to take their medications with them, sort of stigma-related social intentional non-adherence. And so we found that 29% of people in this survey said that they had foregone taking their ART to conceal their HIV status, so other people wouldn't see them taking pills. And so these are examples of items that we have that we call stigma medication management strategies, how people will forego taking their medications, or that's a separate item. Have you skipped or stopped taking your antiretrovirals because other people are around? And so these are those numbers. Those are those 29% of people who say that they've done that. But these are different questions about how they might manage their medications. Do they keep them stored in out-of-the-way places? Do they not take them with them? How often do they worry about people seeing them taking their tablets? We can add those up and have this sort of index of stigma management, medication management behaviors. And what we see is really across the board, it's people that forego taking their medications in social situations do a lot of different things that compromise their adherence to avoid being seen taking their medications. And stigma experiences and medication concerns are both related to intentional non-adherence in this sample. Now, there's I'll talk a little bit more about this in a few minutes, but there's a model that we've really found useful here around adherence, and it's the medication necessity concerns beliefs model. I'll talk a little bit more about that in a second, but that's what those measures are, is they're Rob Horn's medication necessity beliefs, medication concerns beliefs measure. And these findings, as well as some others, have had us really thinking about how we should be thinking about medication-related stigma experiences for people living with HIV and their adherence. So this finding shows that medication concerns beliefs, which have nothing to do with stigma, these are questions like, I worry about becoming too dependent on my medications. I worry that about side effects. I worry about the long-term effects. This is true, and so this is a model that's applied to many different areas in adherence, not just antiretrovirals. And so we find it important that enacted stigma experiences in Cape Town were related to this foregoing of people's ART in social context, but so too were general medication concerns, which have nothing to do with stigma. Or maybe they do. And so in a Poisson regression model, predicting ART adherence over the previous week, we did this hierarchically, and so alcohol consumption in this sample too is related to non-adherence. It just seems to always be. In the next step, we added in the enacted stigma experiences, and we see that, you know, it adds to the model. And then in the final model, when we added in the medication stigma management behaviors that you saw before, they actually account for the enacted stigma relationship. Alcohol, again, stays significant, but it's these behaviors that people may be engaging in to conceal their HIV and to basically protect their privacy around having HIV that account for the relationship between enacted stigma and adherence. In a separate study of 439 people at that same clinic, in this study, we found 24% of people had not taken their ART to conceal their HIV status, basically the same thing. It's like a replication. And in this study, we saw that non-adherence itself is stigmatized. So we've been asking people questions like, if people, these are all people with HIV, and they're all people taking antiretrovirals. And we've been asking them questions like these, you know, having a high viral load is shameful. The sisters or the nurses at the clinic should scold people who do not take their antiretrovirals like they should. And people who skip or forget or do not take their antiretrovirals every day are irresponsible. And what's kind of remarkable about this is the normative responses. When you have 87% of people saying that they endorse a belief, that's normative. So it's like everybody believes it. And there's no difference between those who skip taking their medications and are calling themselves irresponsible and should be scolded by the nurses, and those who don't skip their medications. They believe it just as much. So this is Rob Horn, and his work has actually been quite influential on our research for the past several years. And so he has this medication beliefs model, this pragmatic kind of an approach. He's actually a really remarkable guy. He's a pharmacist by training. He's at London School, and he is by training a pharmacist pharmacologist. And his story, the story he tells is that of course our medicines can cure people. Of course our medicines make everybody better. And of course people are going to take them. And when I learned that actually people don't take their medications, I was stunned by that. And I thought there must be something wrong. And so he's essentially become a clinical psychologist. It's a really remarkable guy. So he has this model, this framework of medication, necessity, concerns, beliefs that is just very pragmatic and very common sense. If people believe that their medications are necessary, they'll take them even when they have great concerns. But if they don't believe that the medications are really necessary, they won't take them even if they have mild concerns. And so there's this balancing. And to me, it just makes perfect sense, right? If you, I always think about like cancer chemotherapy as being sort of an extreme on this. People are willing to go through really remarkable levels of toxicity because it is necessary to save one's life, right? And on the other hand, people like me won't even use a steroid inhaler because that has virtually no side effects because I have beliefs which are totally unfounded that taking a steroid every day must be bad. And so I don't take this medication that could help me, but I'm breathing just fine, so I don't view it as very necessary. So it just makes really good sense that if you can tip the balance where you can have people believing that these medications are necessary and address their concerns, you can probably have a pretty good adherence intervention. And so we've now been conceptualizing stigma in relation to treatment and antiretroviral therapy as a medication concern. So you remember that trial that we were completing back in 2015 that I wasn't going to talk about today. Well, we did finish it, and like many studies like it, it's not unique. It's available through the CDC website. You know, the CDC has a website that tells you about evidence-based interventions that you can now write to other people and get because the CDC no longer has the repository and no longer has the infrastructure to actually disseminate these things because it's been decimated. So the CDC's dissemination is decimated. That's actually a true statement. So this intervention was, we thought it was very promising. The intervention itself is delivered over the telephone. It's 45-minute face-to-face session is what we did in the study in an office, followed by telephone counseling. In the study, it was the CDC. So I fight with the CDC a lot. So it turns out that the CDC said it would have been best evidence, but you did text messaging. I was like, no, that was a separate component. And we showed that the text messaging had no effect. In fact, it might have had an adverse effect. We did daily text reminders. It turned out to be a bad idea. But the counseling would have been best evidence, but it was counseling, but you did the texting. So it's like, okay, screw you, CDC. So they say it's good evidence, but the counseling was very good, right? What's that?
It's being recorded, what you're saying.
Let me just say this. I'm on record. I've never said that our HIV epidemic is the CDC's fault. I've never said that. I just want to say I've never blamed them for this. So, right. And this is sort of our model that we really like. We like the phone counseling because our phone counselors can be anywhere, and our participants and patients can be anywhere. So we don't have to put a highly skilled counselor in every clinic to deliver highly skilled counseling. There can be the vision is to have like a bank, right, of cubicles of the world's greatest adherence counselors on the phone with patients all around the country. That's like the vision. So my counselors in our research are in Connecticut, in New York State, sometimes in North Carolina, though she just moved to New York State. It doesn't matter where she is. And all of our participants in this study were in Atlanta, right? And so we took this as sort of the basis for developing an intervention there. And so we've been working with Kathy Matthews at the MRC in Cape Town, and we did a pilot study. We took that phone-based counseling that we did in the trial that I presented here like 5 or 6 years ago as the basis for the start. We've done this kind of thing before with other interventions that we've developed here. We went through a series of workshops and face-to-face interviews and the sort of intervention redevelopment process that we've been doing to basically translate the intervention that we did here to what it would mean to do it there in terms of cultural and contextualization. And so what we end up with is an intervention that has a theoretical basis grounded in self-regulation theory and Rob Horn's necessity and concerns beliefs model. The intervention that we pilot tested is 5 weekly counseling sessions delivered over the phone. And the intervention setting was a large antiretroviral therapy delivering dispensary and clinic in Cape Town. This was delivered by a trained lay counselor who was based at the clinic, but delivered these counseling sessions from our research space at the clinic. And so we kept the delivery method being counseling. These sessions provide corrective feedback for missed medications and probing social situations and efforts to conceal art. The sessions involve a discussion around intentional non-adherence and stigma-related experiences. There's a personalized adherence plan that includes managing medications while also protecting one's privacy and HIV status. And we use a very standard problem-solving kind of a framework that people have been doing in behavior therapy forever, and as still sort of the core basis for a lot of our counseling. And of course, we reinforce any movement towards better adherence and less intentional non-adherence. So that's like the model. And so in this pilot study, we randomized 50 people to get that or to get a contact match control. And we were just looking for a signal here. So we followed them just for a couple of weeks. This was a test of concept, acceptability, feasibility, and potential for efficacy kind of a pilot that one might need to try to do a randomized trial. And so we did get a signal, actually. We saw that the people that received this STIGMA self-management counseling kind of coaching intervention improved their adherence significantly more than the control condition. When we look at dose, which is not, this is not dose, one should do a dose determination study in order to determine dose. That's a different issue. It's a different problem. But we always look at sort of like, how did people do based on how much they got? It's not dose, because people may engage in this project and take, a counseling session or two and then say, I don't need it anymore, and drop out. And so it's not how much counseling did it take for them to improve. That would be dose. It's just how much did people who had certain outcomes get delivered. But we call it dose because we don't talk about dose properly. And so that's a different thing. And it's because the CDC, no, I'm just kidding. So actually CDC has been very supportive in our hope to study dose. And so that's true. That's a true statement. That's a true statement. CDC has been very helpful. And so, so what we see is, that most people got 3, 4, 5 sessions. They ended up doing pretty well. But people that just got 2 sessions, the person who just got 2 sessions bailed. That person probably didn't need it in the first place. So trying to understand where people come into the counseling and how much to give them is a dose study that we're very interested in starting. We're hoping, well, we're doing it finally. It's been a long haul. We reduced the stigma management concerns that people had, but not necessarily the behaviors. So an important finding here is we ask people, do you keep your antiretrovirals in a secret place so others will not see them? And so people who got the counseling were less likely to do that at the follow-up, controlling for baseline than the control condition. But when you look at the next one, which is take antiretrovirals out of their bottles so that other people will not know they are there, that actually increased, and we gave them pill boxes. And we gave pill boxes to the controls too, but the pill boxes weren't included in any kind of counseling for the controls. So for a person who doesn't get any counseling and is concerned about stigma, pill box is a pretty obtrusive thing, right? It's much more obtrusive than a bottle. But we were able to talk to people about problem solving, how they can use the pill box and still conceal their antiretrovirals, and it seemed to have been a helpful thing. We reduced the stigmatizing beliefs. For some people, they were less likely to leave our counseling, saying that people who don't take their medications are bad people. We improved on some adherence strategies. If you look at the use of the pill box, it's kind of remarkable. I mean, David Bangsberg did a study many years ago in Uganda and Rwanda, I think, that showed that just giving people a pill box improves their adherence in that part of the world. And they're virtually, they should be free. I mean, they don't cost hardly anything. And it's just a simple adherence tool that lets people see if they took their medications that day, and if they did, not to double dose, or if they didn't, it's a great reminder. So we find pill boxes enormously useful. And it's a strategy that our people really went to, as well as being able to keep their medications in a place where they see them. So this now we are actually poised to do this randomized trial. We're just getting started. It was funded just a few weeks ago. And so this is the best, this is all I can show you from that study. We have nothing else to show you. What we will be doing though is enrolling 1,200 people, and we're going to randomize them. And we are.
2025, that's a good.
The next slide. Oh, you can't see the next slide. Don't look. So I just don't know. I just don't know.
I'm laughing at the 2025.
Oh, it's an AIDS and behavior. I can make that decision. So yeah. So there's 1,200 people that we're going to enroll. Very good. That was glad you got that right away. And we're going to randomly assign them to get what I just described to you, this sort of stigma-enhanced self-regulation counseling, or to the non-stigma-enhanced version of that self-regulation counseling, or to a uniform standard of care control group. And this is a study where we'll follow people for a year, and we're just gearing up. So if you have me back in 2025, I'll be really glad to present to you those results, but I have a feeling I won't be invited back till 2030. So in summary, we know that stereotyping and prejudice in healthcare settings fuels medical mistrust and likely impedes PrEP interest. PrEP stigma hotspots complicate scaling up PrEP, especially in racial and ethnic communities, as we saw in Chicago. In Uganda, we're seeing that women in areas of lower HIV stigma have higher testing rates, but for men, stigma was not related to testing, and there's a lot of potential reasons why that is. One is that men may be required to get testing for jobs and things like that. It may be mandatory for men to get tested. It's not that men are volunteering to get tested, but it's not necessarily in a healthcare setting like with women. And so men may resent it, and it may be that actually the more testing in an area, the more stigma there is, not vice versa. Remember, these are correlational data. And there could be some third variable that's impacting both of those things. But what we do know in those data, and it's pretty convincing in Susan's data, is that men and women are responding quite differently to testing and stigma relationships, that those things are just different. In Central Georgia, we see that women with greater internalized stigma who live in areas of higher income inequality have poor viral suppression, and that just wasn't true for men. So it's the same conclusion, that there are differences in the experience of stigma between men and women living with HIV or targeted for testing for HIV, and these intersecting stigmas at the individual and at the contextual level, I think are important and not yet very well understood. Intersectional stigma is an emerging area of interest. We're interested in developing measures of intersectional stigma, but more recently I've become interested in how there's intersectional levels or dimensions of stigma, and that the individual who has a certain unique experiences, let's say as a Black man who has sex with men and is at risk for HIV, how his experiences are quite different in a rural setting than in an urban setting. And so there's almost like this intersectional stigma between race and sexual orientation, which is something a lot of us are interested in. But I think a new idea is how those intersections intersect at the community or contextual level. That, I think, is very interesting. Efforts to conceal HIV can create new barriers to adherence. Art non-adherence is highly stigmatized and can drive people out of care if they're not good patients. I think that conceptualizing stigma as a medication concern offers potential for promising new interventions. So I conclude that in the US, Uganda, and South Africa, and everywhere, stigma does impede HIV treatment and prevention. I'd say that internalized, anticipated, and enacted stigma impact every point along the HIV treatment continuum, the HIV cascade, to varying degrees in rural and urban areas, and that these stigma experiences intersect with gender, race, and poverty. Stigma is a social construction that has become normative in many settings and would require structural changes, and I encourage people to get into that area. I think that it's an important effort. I also, I think it's more likely that we can penetrate HIV stigma than we'll ever have an HIV vaccine. So it's not like it's a hopeless thing for me, but I do think that we need to do other things that we can do right now. And so the stigma mechanisms and the associated behaviors that people engage in are amenable to immediate intervention. And I think that should be our focus of immediate research. So thank you very much. A lot of people contribute to this work. There's a lot of research team spread across Connecticut and Atlanta and Cape Town, and very, very happy to have collaborations with some very talented stigma researchers, that's for sure. So thank you, and that's the talk.
So as usual, you do not disappoint. I don't know why it took us 5 years, but you know, we'll have to do better next time. All right, I'm going to open it up to questions from the room. Well, nodding.
Since Bob's not here, I'm going to channel him. So he has a study where we're measuring adherence using dried blood spots. It's an objective measure of adherence. And now we're trying, in the next phase of the study, we're going to give feedback to participants and their providers as a way to hopefully improve adherence. And one of the things we've been really trying to parse out is how to deliver that message in a way that's not stigmatizing, especially when it's based on something that's subjective, but that might be different than the recipient's perception of how they're doing.
Sure.
So I was curious if you had thoughts on,
Sure.
on that.
I actually have a lot of times people ask me a question, I have to make it up and BS, right? I actually have a good answer to that question. So is it dried blood spots for PrEP or for ART? Is it here or there? Okay. So it's interesting. So our phone counseling always starts with a pill count. So I have to clarify that. What we do is we do our unannounced pill count monthly to measure our outcome. But in this phone counseling, we start with a pill count. And the counselor does that count. And it's not for data collection. It's not for research. It's to start the counseling. So the counselor gets an objective measure of adherence, right, from the participant and feeds that back to the participant right away and says, okay, so it looks to me like you might have missed a dose this since the last time we talked. Do you remember? Does that make sense to you? And if the person says, oh no, I didn't miss a dose, it's like, well, let's count again and kind of walk through the doses that we're counting. And the person may go, oh no, I borrowed some pills, and so that may account for it. But usually, almost always what happens is the participant will say this, I didn't miss a dose. Well, think about what was going on the past week, and the person will go, oh, well, you know what? There was a day when I wasn't sure if I took a dose, right? And so we find this all the time, that people they think they took it, but they didn't. And that's where a pill box can be really, really helpful. So I think, what we try to do is the way that a pill count works is you have to do this, you can't get an adherence on a pill count until you've done a pill count. So the first pill count, you don't get an adherence on in the first session. It's what we call time zero. The next session, we count your pills again, and now we can do the subtraction and see if what your adherence is. So that's 2 sessions now where we can build some rapport. So it's like, I think, any other behavioral intervention where the foundation is being non-judgmental and developing some kind of a rapport, positive relationship with the person, where you're not there to judge them, but you're providing this objective feedback, and it's couched in the whole concept of, people don't remember if they take their medications or not, and sometimes people take them twice because they think they didn't take them, but they did. And it's a perfect opportunity for introducing a pill box. Now, I don't know, we've not done blood spot monitoring for antiretrovirals. Lisa Eaton is doing a study right now where she's using it in PrEP. I think it's worse than pill counts for delivering feedback, which is worse than any kind of WISE pill or MEMS caps. We can't see a pattern of behavior in the pill count. So we can't really say to the person, like you could with a WISE pill or a MEMS cap, so what happened on Saturday? Right? So we don't have that kind of precision. All we can say is, over the past 2 weeks, when I count your pills, it looks like you didn't maybe take 2. And so do you remember anything about that? So I don't know the sensitivity. I don't know I don't know enough to say. Yeah, so I just don't know. I wouldn't know how to deliver that. But I do believe that we are good, that our counselors are good at delivering that feedback without being judgmental and with being a caring counselor and not stigmatizing. So I think that part can actually be done.
Susan and then Paula.
So first of all, I just want to say that I don't have any paper submission in AIDS and behavior, so I want to thank you for giving HIV social science voice. No ulterior motive.
I honestly, my honest response to that is thank you. No, the journal is, I just met with the publisher yesterday. Journal is only as good as the papers that are submitted, and I don't submit to the journal. So it's a matter of personal policy. I don't publish in the journal. And so if you think the journal is good, it's because of you and the other people that submit to the journal. I'm basically a traffic cop.
So 21s. And when I was looking at your pilot and how compelling it was with the 25 and the 25 people to be moving the work forward, I wondered if there were R21 support for that, because I think we all try to talk at the fellows level and beyond about how can we get the support to do smaller studies, to get the pilot data so that we can show the signal.
Yeah. Yeah. So I think it's a huge challenge for people in a lot of places. As it turns out, Kathy Sickham and I had a good mentor this way. He really believed that the best way to learn about how to do an intervention is just to do one, and to do a small scale one. So I think that we had a particularly good experience in how to sort of put together a small scale RCT. But you still need resources to do that, you know. And so the truth is that's a pretty small scale. I think the way I always feel about these kind of pilot studies, especially for people that are proposing R34s, is there's like a sweet spot. So if the pilot is too good and too big, reviewers are likely to say they don't need to. They've already done it. They've already done it. If it's too small, it's not necessarily convincing. I think we were on the small end, and I was a little concerned actually that it could be reviewers weren't going to buy it, that it was too small and too short of an outcome. Having said that, it flew, but we got the resources to do it because the University of Connecticut, which isn't, I have probably as many good things to say about the University of Connecticut as I do the CDC, but one nice thing is that they actually is a small return on indirect costs. So we do get some money back each year, skimmed off the top of our indirect costs for this very kind of thing. And a study of that size and that scope generally costs us about $25,000, $30,000 to sort of pull off. And so we do get that back. I think it's I think we're fortunate to have that. I think if you don't have that, you should leverage it. I think that, you know, an office for vice president of research should be able to front up promising things. A lot of centers have seed grants. So our institute has seed money that comes from the office of the vice president for research that people can compete for. And I'm sensing this is an uncomfortable question. It's just, I'm sorry, but I mean that's a yeah.
No, I appreciate that. And then I did have a specific question. I wondered if you had measures of social support or network empowerment, because I'm wondering whether folks who have other people who are empowered as people living with HIV and who get to talk to each other about pride and, you know, efficacy and stuff like that, whether you have a way to measure whether you're affecting that or whether it has an effect.
Among center directors to leverage funds? No, you mean in the study. So, you know, the other thing I would say just about the money though is actually if you have money at the end of a grant, we've also been successful in talking to program officers and saying, can we use that money to, and sometimes program officers are willing to do that if it's not too far outside of your scope of your original aims. But anyway, so we use the Saracen measure of social support, but something we've been recently using. In fact, we have a paper that actually is coming out in a journal that Tim Heckman edits, the Journal of Rural Mental Health. Is a paper coming out where we, for the first time, measured social capital using a network measure. We used Carl Latkin's network measure. We kind of reconfigured it, sort of like Amy Knowlton has around social support for people with HIV. And so we measured social capital. We had a very good question from a reviewer of that paper saying, how is this really different from tangible social support? We struggled to answer that question. Our measure actually is tangible social support at the network level. And so the difference between what we measured as social capital and tangible social support was just we were able to look at it by relationship. So do you get these tangible supportive things, people that help you out, could borrow money, things like that, from these specific relationships in your network? But it was actually a question from a reviewer that we struggled with. I think that if we were to do this kind of thing again, we probably use the network approach to measure social support, but be more thoughtful about the types of support we were drawing to be able to differentiate social capital from tangible support. Although, to be honest with you, looking at the literature, I'm not sure that's so easy to do. It was a very insightful question of a reviewer from this really excellent journal by a really excellent editor.
Oh yeah, so I wanted to ask about what's your thoughts on perceived stigma as just like a construct for further exploration. It seems like it might be a little bit understudied, and I did read a paper by Lisa Eaton, came out last year on HIV microaggression. I thought it was really interesting, right, because it's probably the accumulation of these kind of situational, someone not sharing food utensil, someone not holding the door for you, things like that, that could be perceived as discrimination, whether it is or not. So how do you think that relates to enacted stigma, how that can stand on its own as a construct, and how we can explore that further, and how we can measure that?
Yeah. So there's like a lot of these kinds of measures, and I like some of them, and I don't like others. Our measure we use, we've really been developing, and it stems from Valerie's work, but her measure I found to be too, she's asking more about healthcare related stigma experiences, and I really wanted to get out of that. And we don't really care. I mean, we care, but we don't, it doesn't matter to us in terms of measurement if it really happened or not. Lisa Eaton's kind of the driving force behind a lot of our work, actually. And she said this when she was a graduate student. She said, it doesn't really matter. It's what people believe. It's people's beliefs that drive their behavior. And I just, over time, I've really, at the time I wasn't so sure, but over time I've really come to believe that myself. And so, our enacted stigma measure we're asking some things in the thing we're about to launch about experiences you may have had online in terms of experiences of discrimination and hate kind of experiences. And so we ask people, we're going to be asking people, this is a measure that exists, but we've tailored it to our study. We're going to be asking people if they've had experiences where they've been insulted because of their online profile, if they've experienced where people have said that what they post can't be trusted, things like that. And so, I think those are like really interesting questions. And whether or not it actually occurred, it doesn't seem to matter. What seems to matter is that people feel like they're being assaulted, insulted, violated, discriminated against, judged. I'll see what happens in the study we're about to do, but I'm also asking some questions that are much more general, like, have you felt like you've been stereotyped online? And not necessarily stereotyped for any particular thing, but do you feel like people stereotype you? It seems like in common language, people will know what that means. But, and so we have a series of questions like that. Have you felt prejudiced against? Have you felt like you've experienced discrimination without necessarily, making it specific to an event? We'll still have those questions too. But we think that we might be losing people's experiences of feeling that they've experienced discrimination because the things they've kind of attributing to the discrimination aren't in our list. So it's not that they've ever been evicted from housing. It's not like they've ever been, those specific things that we ask that the 20 things we could think of, they're not necessarily in their life experience. So just ask them if they felt like they've been discriminated against.
Seth, can I ask an internalized stigma shame question in the context of a structural intervention? So I'm wondering what you think, if I heard what you were saying about the Cape Town context in particular, about how for women the internalized stigma is related, yet you're, I think, advocating for structural interventions, which is great. But what your thoughts are and what's the social context synergy that makes the shame and internalized stigma have a negative effect that you could potentially change through a structural intervention?
Yeah, so I think you're right in saying I would advocate for people to do that work. I'm not engaged in that work. And so I was recently at a meeting where Kim Blankenship presented, and she let off her whole thing and then kind of did her whole thing around how, you know, you can build all the lifeboats you want, but until we build better ships than the Titanic, you know, ships are going to go down. And I'm like, you know, we need lifeboats. And there have been a lot of efforts to destigmatize HIV. And I don't believe we're getting the dividend that we were all sort of promised, which is that as HIV becomes more of a treatable disease, more of a chronic illness, more like diabetes, more like cancer, not a life sentence, not so perilous, no beliefs about contagion, we're going to get a stigma benefit from that, where there's like a stigma dividend, and it's not being paid. And the reason why it's not being paid is because HIV is not stigmatized. It's all the baggage with it. It's all the beliefs that people have around it. And that just may take generations to cleanse. That's my view. It's sort of like generational turnover is probably the structural intervention for stigma reduction, because we don't see the same kind of stigma around cancer that we used to, but we do see stigma towards smoking that we never did, right? But it's very generational. And so I think that there's a hopeful part to that, which is that a new generation may be less homophobic, less drug stigmatizing, less poverty stigmatizing, less sexist. I don't know, does that sound like a hopeful message? Because unless that's true, HIV stigma isn't.
Can I ask a thought? I thought Kathy might go in this direction, given her work, but I guess the other question I have for you, and I don't think you talked about it, is the role of violence. And thinking about the differences, the gender differences that you found, and the real threat of violence, particularly for women in many of the contexts you're in, and how you think that plays into this, or where?
Oh, I think it plays greatly. So I think the power difference, I think that probably a very likely third factor in all of that is, because it's very correlational, right? Our power differentials and the consequences, and we talk about this in our research group a lot, the consequences for women around STD-related stigmas are enormously different than men. And so it makes sense that stigmas that are attached to HIV would be very different for men and women, and that would vary by these, you know, like, for example, urban, rural kind of context. So the sort of social repercussions, including threat of violence, are I think, higher. It's not like men are immune from those things, but I do think that there's well-known gender differences. And so I think it's really why people have become very interested in intersectional approaches to stigma, which is really the biggest gap, I think, in my talk, is I just sort of alluded to intersectional stigma. Reality is it's really where the field is right now in stigma, is trying to figure out intersectional stigma. And the first step to that is measurement, really. And so the NIMH had an RFA last year soliciting proposals to develop a measure of intersectional stigma around PrEP. And so there are a good number of people trying to develop measures for intersectional stigma. And we're one of those groups. We're definitely trying to do that. But I'm actually more interested in intersectional stigma as it may be parsed out for people living with HIV. Can you kind of disentangle? I think mathematically we've figured out an approach, and if it works, I think when you parcel out, for a Black man who has sex with men and is HIV positive and experiences HIV-related stigma, I think that when we are able to parse, the hypothesis is, when we can parse out the homophobia that he experiences as a Black man who has sex with men, and the racism he experiences as a Black man who has sex with men, there will be no stigma left. That the HIV-related stigma that he's experiencing is accounted for by his experience as a Black man who has sex with men. But we'll see. I think we figured out the math on that. Actually, Bruno Schemke suggested that we, I'm not real good in math. He suggested that we use the Pythagorean theorem. And I think it might work, actually. Because it's like intersecting right angles, right? So it's like the, and I'm like, How did he think of that?
I have a question from Bob, but only if there's no one else in the room who has a question. So I want to, all right, I'm going to ask the question then, although I don't completely understand it, Bob, so the last part of what you said. But he would like it if you could say a little bit more about the influence of the broader context of high versus low stigmatizing areas and how that interacts with individual level feelings of stigma.
Yeah.
And then he wrote, meaning the community, society, culture, government, policy, etc.
Yeah, I think I understand. And so, I mean, that question directly relates to the whole GIS analysis. And so it's based on distance metrics, right? So you can have a high stigma score, but if your neighbors have substantially lower stigma scores than your high and low. And so it's nice, I think it's nice way to understand some of these things, because there are areas where lots of people that have low stigma scores are concentrated, and high stigma scores are concentrated. And then there are individuals, though, that don't necessarily line up with their neighbors. So I think actually for the Uganda study, where I probably thought about this the most, I think that for women, it just seems to ring true to me and make sense. That women who are going to health facilities and are in a place that has less HIV-related stigma in these villages and around them are more likely offered testing, that testing is more likely frequent, that at the clinics that they go to, they're more likely routinely, because the social context is less stigmatized. And so women who had high stigma scores themselves were more likely to get tested than women in high stigma areas who had low stigma scores themselves. So testing isn't like something you just do, right? Testing is something that has to be available, accessible, and offered. And so it makes sense that in a low stigmatized area that would be true. And so all women have that experience. And for men, the best that we can think of with men in Uganda is that there's the same kind of thing is operating, that in highly stigmatized areas, there's more HIV presence, more testing happening that's for men in those settings. And so that there may be, and another thing that one of our team said was, maybe because men who live in high stigma areas and hold those beliefs themselves find it so distasteful. They want to make sure they don't have it. They keep getting HIV tested because they keep testing negative, and they want to keep confirming that they're HIV negative. I don't know. I think it's an interesting question, and for me, the gender difference between what we're seeing in the Ugandan villages and the gender difference that we're seeing in the rural areas of Georgia, that everything about stigma and its relationship to testing or engagement in care for women makes sense. It's what we would predict. Less stigma, more testing, more engagement in care, and not for men. And there's something very different about men's experience and how that relates to the environment that they're in than women in their experience in the environment that they're in. And they're in the same, it's not like these villages are segregated, you know, they're men and women in the same places. So I think it's sort of a pressing question of the time in understanding stigma.
So thank you very much. Bob says, thank you for that response. Benefits of technology. So it's 11 o'clock on the dot, and I really want to thank you, I think, from all of us for, again, you know, being at the forefront of what's a really critical issue and really taking us to a different level of understanding on it. You did not disappoint, as I said before. So.
There are two behavioral things mentioned in the OAR priorities for HIV research. Right? There's adherence and stigma.
Yeah.
That's it. That's all the OAR sees. So.
Well, thank you very much.
Thank you very much.